Okay. So when it comes to schizophrenia, what do you guys generally think about, or like what do you guys generally know about it? It's crazy. When it's unmanaged, it does come with a lot of hallucinations, comes with a lot of delusions. Definitely. That's fair. That's a fair one. So when it comes to schizophrenia, you can break it down into what's considered positive and negative symptoms. So when they say positive and negative, they don't mean like this is a good thing versus this is a bad thing. Um, the way you can think about it is if your baseline is like at zero, like a average person is at zero, a positive symptom is something that adds on to your baseline. So something that you don't have that is added on. So for example, that would include things like delusions. So thoughts, additional thoughts that aren't there on an average person, hallucinations, sensations that aren't there on an average person, illusions, which is kind of like adding on to things that you already see, and then also changes in thought content. And then kind of going back to that, a negative symptom is kind of going on the opposite direction. Instead of being something that is added on to your baseline, it's your baseline, but less. So decreased showing of facial expression and emotions, decreased energy, decreased in like ability to enjoy things, decreased ability to do your activities of daily living. You might not get out of bed. Might not want to do anything. Um, so that's kind of what they mean by positive and negative. Okay. Does anything that you guys kind of see so far look familiar? Anything that doesn't look familiar through like all this part right here? So the neg kind of like the examples of negative symptoms, examples of positive symptoms looks familiar. Okay, that's good. Is there anything in particular that is difficult to understand for you guys that you guys want me to go into more detail or just kind of go through it again? Like go through it top to bottom. Okay, so we'll just top to bottom. Yeah, that's fine. It's fine with me. It's fine with everyone else. Yeah, cool. So delusion. So what like people get the word delusion confused with hallucinations or illusions a decent amount. So a delusion is just is your thought process. So when you say someone is delusional, it's because the way they're thinking is abnormal. It's not what the average person thinks. So some examples of that is paranoid delusions. So paranoid delusion is some like having paranoid delusions is someone that is thinking that people are untrustworthy. They're possibly out to get them. A surprisingly common uh, delusion is the thought that there's cameras in my room, there's gas leak in my room. Um, that person looked at me weird. I think they are out to get me. Those kind of thoughts, which is very similar to the persecutory, which is very specifically like people are specifically out to get me. They are very similar in that sense, but persecutory, it means that they have that feeling that somebody is out to get them. The FBI is against me, is coming after me. The CIA is coming after me. Um, aliens are coming after me. I've heard that one. Uh, Okay, so paranoid and persecutory is just thoughts that someone is after them. Everybody's their enemy. There's things going on around them. There's a experiment. People are experimenting on my DNA. Um, yeah, that kind of idea. Grandeur delusion, so otherwise known as like delusions of grandiosity. So you could also call this one like grandiosity. So kind of from the name, grandiose means kind of like somebody's like super important. So they feel like they are super important. They are the best. Nobody is better than them. So people would a lot of people think like, oh, I'm God. I'm literally God. I'm literally like super important. I own this hospital, actually. You're working for me. Um, those kind of thoughts. So this is a common trait in mania as well. Uh, Similar to how you'll see some of these negative symptoms are similar to the depression. So grandiosity can still exist with schizophrenia. Um, Erotomanic, kind of the word like erotic is somewhere in there. It's just it's the belief that people are secretly in love with them. So they think people are on them, are in love with them. There's also somatic, which definitely has a lot that you can talk about, but the idea of a somatic delusion is that it's a false belief about the body. So there's people that have beliefs that they're not able to walk, even though there's physically nothing wrong with them. It's like a mental block due to trauma can happen a lot of the time. That causes them to not be able to walk or not be able to see. In this case, someone with schizophrenia might have like stomach aches when there's nothing wrong with them, just because they're attributing these additional um, these the as part of like their delusions that they're having stomach pain, and they might actually genuinely feel that stomach pain, but there's physically nothing causing a stomach pain. There's no issues with their GI, etc. So that is somatic. So false beliefs about the body. Ideas of reference. You'll probably see this one put a lot. It's a pretty common one to get tested on. So ideas of reference means that they think that things are referring to them. So they see a TV show, they see a music video, and they think that's talking about me. Like, oh, that music video, that song is actually talking about me. When they're um announcing like the next mayor or the next president, there's like, oh, that they're talking about me actually. Um, and then there's also thought insertion and withdrawal. This is the delusion that they can put thoughts into other people's heads or that other people can read their minds and take thoughts from their heads. So these type of people might um, have the delusion that they're making people do things. So they might have in their head like, oh, I'm gonna insert my thought and have this guy do this. And depending on how far the delusion is, they might see that person do an action and they'll be like, yep, I did that. That was me controlling him. Okay. Any additional explanation needed for any of these? So delusions is just abnormalities in the thought pattern. Okay. And then when it comes to hallucinations, hallucinations are sensory based. So your senses. So the most common ones are going to be auditory and visual hallucinations. So auditory hallucinations that can present as voices that tell them, negative things, voices that maybe just narrate the what's happening around them. Those voices can be female, it could be male, it could be of any age, it could be a family member. Um, I've even heard someone describe their auditory hallucinations as they hear music, and it's even possible to have auditory hallucinations where you have a voice telling you to do things, which is kind of the scarier one. Those are called command hallucinations because they're telling you to do things. So when it comes to like assessing someone with schizophrenia, you just kind of want to ask them like, "Hey man, do you see anything that other people don't see? Um, like what does the voices sound like to you?" You could ask them like, "How does that make you feel? Do they ever tell you to do anything? And if they do, like, do you listen to them? Do you do you know that if you're having these voices telling you to do things, like maybe you need to come to the nursing station and get a PRN, because these thoughts could tell them things that might harm them. Like it could literally tell them to kill themselves. It could tell them. I had a patient whose voices told him to stay in his room, don't talk to your mom, um, stay out of the house, don't come into the house. So in that case, like he locks himself out of his room, he locks himself out of his house, no shelter, not able to get food. So you're harming yourself because you're not able to provide your basic needs. Or or they just straight up tell you to kill yourself and they might go through with it. Or they tell you, kill this person, hurt this person did this, you need to punch them. So that's kind of where that goes with auditory hallucinations. There's also visual hallucinations, which is seeing things such as they can see shadows, they have hallucinations that someone is coming at them with a knife. But the most common thing is the auditory for sure. Visual, I would say, is the second most common. Tactile, and the rest are less common for sure. I've seen tactile more than I've seen the other ones though. So tactile would mean that you feel things that aren't there. Maybe have thoughts. You have the feelings that there's ants crawling all over your skin, insects crawling under your skin. You feel like your shoulder just got tapped. Olfactory is smells that aren't there. You maybe smell something in particular. You smell a dumpster, like you smell trash when there's not trash anywhere, or you smell, like an apple pie when there's nothing being baked. Gustatory is tasting things that aren't there. So straight up, like you're not eating anything, but you have a taste in your mouth. It tastes like bleach in my mouth. Tastes like dumpsters. Like literally, I'm eating trash in my mouth. But yeah, hallucinations are sensory based. Illusions are purely thought. The way to remember it is just like, when you call someone delusional, you're telling them that the way they think is not normal. When someone is hallucinating, they're on a trip, like they just took mushrooms or something, shrooms, they're seeing things. So that's the way you can try to remember the difference between them. When it comes to illusions, this is just a misinterpretation of what things are actually going on. They add on to it. So the example I provided is looking outside, seeing a ghost fly, but it's just shadows from a tree. So they saw the shadows from the tree and their brains added onto it. Pretty pretty similar to a hallucination, depending on who's assessing or who's interpreting it, could be seen as like visual hallucination, but they are pretty similar. But I would focus mostly on delusions and hallucinations for that. Next, there is like changes in their thought content. So these are some phrases that you will see. Flight of ideas is having a flight of ideas means you have a lot, kind of like racing thoughts. You're rapidly switching between a bunch of topics, but they're all connected. And this is something you might also see in mania. So mania is like everything elevated. So it kind of also aligns a little bit with like those positive symptoms where it's like added on to your normal baseline. And then also why it's very possible to have mania with psychosis. Just have like that elevation of all your senses of all that you're feeling. And then kind of as we go from flight of ideas down to this word salad, it's going to be kind of like it's like progressive. So yeah, flight of ideas, you're shifting between a lot of things that are connected. And then there's loose associations where the thoughts are only vaguely connected. So you can, they don't have direct correlation, but you can kind of tell how they got there. Like, so for example, maybe they're talking about their medications and then they shift to talking about their dog because their dog was on medications. And then they're talking about their mother because their mother has that dog. Um, like they're vaguely related, but they're not directly related versus like a flight of ideas. They have a more coherent line of thinking. And then even more abnormal than that would be like a word salad, meaning that they have no connection between the thoughts. They're saying a lot of words, but they don't really connect to each other. There's no real way to be able to interpret what they're really saying. So, in clinicals, you'll probably see people with mainly these two. The word salad would be definitely a lot more severe presentation. Thought blocking, someone that is thought blocking, kind of like in the wording, it just means that they're having a hard time getting their thoughts out, having a hard time being able to speak out their thoughts, having a hard time thinking. So, I had a patient who was very, very thought blocking, weren't really able to tell me much about how they were feeling. When I asked them, do you have suicidal ideations? Do you have thoughts of wanting to hurt yourself? It took them a second to think. They said, maybe, I don't know. And then even when like giving this person medication, they would kind of just look at the medicine and the water and they wouldn't really know what to do with it. They would have to be explained what to do, like how to drink things, how to eat things. Their activities of daily living needed a lot of redirection, needed a lot of encouragement, or else they wouldn't do them. But that would be thought blocking. So someone that is mentally unable to bring out their thoughts, bring out some of their actions. Magical thinking is kind of like the idea that I have literally you have magic. I have the power to do this. I have the power to do that. Or this happens because, or maybe you can think like, oh, this is happening because the stars were aligned in this certain way. So kind of like a superstition, kind of like a hardcore superstition, magic-based thinking. Like you make correlations and you kind of justify things, rationalize things through things that are magical. Some other ones here, echolalia. So echo like noise, lalia would be like repeating. So someone that is either like you tell them like, "Hey, how's your day?" They'll be back, "Hey, how's your day?" Do you hear the how's your mood going? How's your mood going? They'll just repeat what you're saying back to you. Concrete thinking is kind of the thought process of a lot of patients in the psych facilities. It is a very literal way of thinking. So kind of like the thought process of a um, kind of an older child where they might not understand phrases, phrases of manners of speech or phrases or similes or idioms. So when you say like, "Oh, you let the cat out of the bag," they'd be like, "What cat? I don't have a what cat? I didn't get any cat out of the bag. There's no cat. Where's the bag?" Like they just think very literally about things. So if you speak to them in phrases, they might do whatever the phrase is literally saying, as opposed to what the implied meaning is. And then lastly, preservation slash repetitive is someone that stays on something for an extended period of time. So for example, they'll just be like talking about your badge reel, for example. They'd be like, your badge, 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 badge. They just preservation, like they stay on that one word or that one line of thinking constantly. Okay. And is there any questions on like the positive symptoms? So again, I would focus mostly on delusions and hallucinations, but that's kind of the idea that you're getting at with like all that thought content stuff. Okay. Was any of this new? It was any or was any of this new? Was most of this familiar? All right, cool. All right, good. Do you guys want me to go a little bit faster on this kind of stuff if it's basically just the same as very similar as to what she said it, or do you think it still helps to kind of go through it? It helps to go through it. Okay. And then if you have any questions, just ask me examples. Sure. Okay, so negative symptoms. So like I said, if you imagine your baseline is at zero, positive symptoms add on to what you have. So it adds on these thoughts, it adds on these sensations. Um, Again, it adds on these thoughts, while negative symptoms take what you already have and just decrease it. So it takes your mood and your the facial expressions and decreases how they are, makes them more restricted, unable to express yourself, um, takes your energy, takes your ability to enjoy things, takes your ability to care, and just decreases it, which a lot of these can be very similar to depression. So you can kind of break them into A's, so it's a bunch of A words. So affect. Affect refers to the way that their face expresses itself. So having a congruent affect would be having an affect or having like a facial expression that matches what you're feeling. So if they're happy, they smile. If they're sad, they frown. If they're laughing, they, have that laughing expression. Someone that has negative symptoms, so someone that might be depressed, someone that has these symptoms of schizophrenia, they might have a flatter affect, a restricted affect. So they're not really able to show you their emotions. They might feel those emotions, but they might not look it. They might have that kind of like stone face, like they don't feel anything. Um, there's different stages to it. So having a restricted affect means that their ability to express themselves through their face is not fully congruent, not fully what is considered normal. A more blunted or flat affect means that it's even less, they're showing even less emotion, maybe even not showing any emotion, completely flat. And I think the affect definitely makes like a large difference in sometimes you kind of just get a look and you can tell that this person is either having like negative symptoms of schizophrenia, having um, depression, or they're just very, very heavily medicated just based on the way they look, based on the way that their affect is, because they're super flat. They're either very flat because of the meds, they're very flat because of how they feel, or they're very flat because of their condition. So I could probably Google that and get Flat affect. Kind of get like a actual visual. Let me see if I can find a really good one. This one's actually not bad. So this would be like a flat, and like imagine you're talking to them and like you're talking about some casual conversation, talking about her cats. But this is the kind of fa this facial expression kind of stays on them the entire time. And you might also hear it in their voice, like very mo more monotone kind of sounding voice. Okay. Ambivalence. Ambivalence means that you're not really going towards one way or the other, so you're having a hard time making decisions. Your thoughts are very disorganized. Um, just unable to kind of organize the way you're thinking. You might do one thing and then want to do a different thing. So there's no order to your thoughts. There's no um, proper decision making. Maybe you're not able to decide if you want this or you want that. You're gonna start doing one thing, you start doing the other thing instead. You don't have that consistent thought pattern, not able to kind of stick to one thing. You're also just kind of all over the place is another way to kind of think about it. Asocial, meaning that they're not really socializing, they're kind of in their own little world, not interacting with other people. So it's very common for them to be isolative. Maybe they'll be like in a psych facility, they'll be isolative to their room or they'll just stay in their own little corner, not really minding other people, just kind of in their own world. Maybe they're responding to internal stimuli, which is a phrase we went over last week, meaning that they're talking to themselves. So sometimes they'll be pacing, they'll be talking to themselves. You'll see their mouth moving, or maybe you'll hear them slightly, just talking to themselves, talking to their voices basically, and not really taking what's around them in their mind. They might not be able to really tell what's kind of going on around them because of all the voices that they hear, maybe some of the things that they see. They might not even be able to tell apart what's real versus what's not real. So like I've seen patients talk to a wall, for example, or they're talking to their voices and it's difficult to get their attention because they're so focused on their own thing, very focused on what's happening in their head. So you can also call that like they're very internally preoccupied. They're very internally preoccupied. They're responding to internal stimuli, right? And then for um, you know, responding to internal stimuli versus internally preoccupied. Someone can be internally preoccupied if they're just like ruminating, they're thinking about their thoughts, maybe they're depressed, they're just in their head thinking about past events. That could be internally preoccupied. So someone can be internally preoccupied without having to have voices or seeing things. It just means that they're in their head thinking about themselves or thinking what's going on around them. But sometimes with people with schizophrenia, that is they're internally preoccupied because they're kind of just with their voices in their own kind of world, versus like responding to internal stimuli, which is you will physically see them act um, on what they hear and what they see. Usually, this would be them mouthing and like kind of mouthing some words, or they're talking to themselves, talking to their voices, or maybe they will ha like if they have tactile hallucinations, maybe they'll just kind of turn around quickly because they felt someone touch their shoulder or they feel a presence behind them, so they quickly turn around to look behind them. That would still be like responding to internal stimuli because what they're hallucinating, they can't tell apart from reality, so they are responding to it as if it was a real stimuli, like a real thing that is occurring. Inertia, meaning that they're lacking energy, just lack of energy, lack of motivation to do things. So again, very similar to depression in that sense. Anhedonia refers to like a lack of pleasure. So things that they might have enjoyed doing in the past, they don't enjoy doing anymore. Apathy, lack of emotion, so kind of goes with some of the other ones. And appearance deterioration due to a lack of people doing their activity of daily living. So they're not getting out of bed. They're not having the energy to take care of themselves. They're not taking showers. They're not brushing their teeth, not cleaning up after themselves. They haven't changed their clothes in weeks and days. They spill something on themselves. They just leave it there. They're very odorous. So a lot of these very similar to depressive symptoms. So sometimes it can be if you have like a patient that's not the best historian, maybe like telling apart schizophrenia with having the active negative symptoms versus like someone that has major depressive disorder and having a psychotic episode might be difficult to tell. So you might have to kind of just wait out, kind of see if you can get better history from them. Um, because kind of like previously mentioned, somebody that has either mania with psychotic features or depression with psychotic features, those psychotic features only appear during their mood episodes versus schizophrenia, where you are having the hallucinations, the psychotic episodes, or having delusions, hallucinations, etc., all the time. Um, and then the separate, maybe negative symptoms appear at separate periods during different phases of what you're feeling. So schizophrenia also kind of operates in different phases. So you'll have some where you're more more towards this positive symptom side, more towards the negative symptom side, and some where you're kind of in between. So yeah, so patient can move in and out of some of these phases, so they can have those subtle scent changes. So the start might have some of these negative symptoms go on, some odd behaviors, and then have full blown hallucinations. And then as you treat them, uh, you'll definitely see an improvement on, well, hopefully you'll see an improvement on their positive symptoms. Some of their negative symptoms might still be there. And then when we go over the meds, you'll kind of see why that could be the case. Just a lot of the medications tend to be more focused on treating the positive symptoms than the negative symptoms. Okay. So then, to talk about the meds, I think it's important to talk about the neurotransmitters. So, the way that schizophrenia works, it is not entirely fully, fully understood slash fully able to be assessed in a way because we can't necessarily measure the levels of neurotransmitters in the blood or in going on in the body. But the idea is that dopamine is overall increased in schizophrenia. So for some pathways, overall, you're going to have more dopamine than normal, but it kind of depends on certain parts of your brain. So in some parts of your brain, there's too much dopamine activity, which causes the additional positive symptoms to act up, hallucinations and delusions. In some brain pathways, there's too little of it, so you have those negative symptoms. But overall, you can say that there's an increase in dopamine. So we'll see that the medications target dopamine in particular. And then there's also going to be some issues with serotonin. Serotonin is going to be your neurotransmitter that deals with your mood overall. So this can contribute to some of your mood symptoms because serotonin can be not properly regulated in schizophrenia. There's other neurotransmitters that can be relevant, but I don't think you'll need to know them. I think the ba major focus is going to be on dopamine and serotonin. Glutamate, this is the excitatory neurotransmitter. So when this is high in patients, they're more prone to seizures. This is the part of the brain that allows for transmissions to happen. So, but overall, it's going to be decreased for them, leading to those negative symptoms, difficulty with memory, cognition, while GABA, which is your inhibitory, is also decreased, which leads to the poor regulation of their activity, their disorganized thinking. Um, yeah, and then GABA, you might remember from like when you're doing when you guys were learning about seizures. A lot of the medications for seizures increase your GABA because Um, if you have too much excitatory and not enough inhibitory, that's when your brain starts sapping all over the place, and that's where you get seizures. But in this case, they're decreased on both. There's a few different types of schizophrenia. So catatonic means that the patient is just not really moving. They're just kind of staying still in one spot. Might not even talk to you, have a hard time talking. So that patient that was thought blocking, she was pretty catatonic. She wasn't really moving around. She would just sit down and stare towards the TV, without even actually watching the TV because someone tried to change the channel or like switched it up to the TV guide, just left it as the TV guide, and she was still kind of just blankly staring at it. She wasn't really watching TV. She was just kind of sitting down staring. Uh, and there's also a waxy catatonia. So this means that if you were to lift their arm up, their arm will actually stay up. As opposed to with normal catatonia, if you lift their arm up, their arm will come down because they're not really moving. They're not really putting effort into movement, keeping things up. But waxy catatonia is like however they're set up is how they're gonna stay. So if you lift their arm up, it will stay up. The most common one is paranoid schizophrenia. I believe now, the way the current DSM-5 is, the different types of schizophrenia, they just kind of correlate. They just kind of combine everything to schizophrenia. It's just broad schizophrenia. They don't really use the different types as much, but a lot of people still will use them because that's how they learned it. So paranoid schizophrenia is like the typical thing that you think about with schizophrenia. They're gonna poison me. Um, like people are after me. Like they're trying to hurt me. So a tip for patients that are very paranoid and think that you're trying to poison them would be opening the medication in front of them. So even when you're not in the psych facility, like if you're in a medical floor that happens to have a large amount of psychiatric patients, county, for example, gets a lot of people with secondary psychiatric conditions. This is something that you might have to consider or think about is like that you might have to I mean, you probably have to do that anyway per policy, but like opening the medications in front of them, yeah, opening their meds in front of them just to so that they kind of like, well, I'm the nurse. I'm not. My job is to help you, to give you your medications and help improve your condition. I'm not trying to poison you. Here's your medication. You can see that it's unopened. There's the name right there. I'm gonna pop the pill. There you go. Okay. Any questions with schizophrenia so far? I'll quickly go over schizoaffective, go over some of the consequences, and then talk about like the medications before going into ADHD. Okay. Did you guys go over schizoaffective much, or if at all? You did? Okay, cool. So I'll just quickly just kind of refresh. So schizoaffective, there's a few different types. It's basically a psychosis, a consistent psychosis, consistent hallucinations, delusions that are paired with a mood disorder. So there's going to be a bipolar type and a depressive type. So either their mood episode is depression or their mood episode is either mania or depression. So in terms of like how do you tell apart if somebody is bipolar with psychotic features versus they're schizoaffective? It would be what is the primary issue? So if somebody is bipolar with psychotic features, the psychosis is only occurring during a mood episode. When they're stabilized, they don't have psychosis, while somebody that is schizoaffective always has those psychotic features, and then they have the occasional or they have the mood episodes that come when they come. But that hallucinations, the delusions are not tied to their mood episode. The treatment, however, is more or less the same. It's basically like treatment for schizophrenia, but adding on some of the medications for bipolar that we talked about last week, like lithium, mood stabilizers like valproic acid, lamictal, and then depending on what they have, maybe antidepressants like SSRIs or Wellbutrin, etc. Now, another thing that I think is important is going over the some of the side effects, some of the possible complications. So when it comes to your medications, you have extrapyramidal symptoms, otherwise it's called EPS. So if you guys recall, like I mentioned, the schizophrenia is believed to be partly caused by an overall increased amount of dopamine. So the idea would be that your medications target dopamine, decrease the levels of dopamine in the body. But if you guys recall from last week, dopamine is like do it dopamine. When you have too little of it, you can't do it. You can't do things. You can't, you have those Parkinson's-like symptoms. You have rigidity, you have trembles, you have shaking and tremble. So when you decrease that dopamine by using medications, that's when you get um, those Parkinson-like symptoms. And the exact pathophysiology, like you see here, I mentioned like acetylcholine excess. So dopamine, acetylcholine, uh, there's a lot of between the neurotransmitters, there's a lot of relationships that they all have. So in this case, when you have a decrease in dopamine, you end up having too much acetylcholine, which then leads to your Parkinson's-like symptoms. The reason I even bring this up is just like if you guys go over Parkinson's, you'll see that the medications to treat it are going to be medications that decrease your acetylcholine overall. So that's kind of the patho behind that. I would say the main thing you really need to know is just decrease in dopamine, Parkinson's symptoms. The in between is just for context for when you guys go over medications for Parkinson's, or if you have already have done that, then nice. But medications for Parkinson's include things that prevent the reuptake of acetylcholine, so overall decrease your acetylcholine. And this is the reason why. So some of the symptoms that I talked about, tremors and rest. You can have what's called the oculogyric crisis. Oculo like eye, gyric like movement, like movements like kind of spiraling around. So if we kind of look this one up, we'll see that this is essentially a situation where your eyes are just kind of either going up or they're kind of going everywhere. You're not able to control your eye movement. So that's kind of pretty scary. You have rigidity. Your body's very stiff. Uh, Akathisia, which means restlessness, and a pronator drift. So when, for example, what is a pronator drift? When somebody has a history of stroke or you're trying to test them for stroke or some sort of deficit, some sort of drift deficit, what you would do is you have them have their hands sticking outright, sticking out, and then have their palms facing up. So if they have one-sided weakness, you will see one of their sides. They're not able to keep it. So it's not just going to be the arm swings down. You'll also see their inability to keep their palms up. So their palms will start to shift down to palm down, and then they'll start moving their hand down. So a pronator drift, you can do that for like a stroke or just having one-sided weakness. But you can also kind of see it with these psychiatric patients that have EPS due to their medications. So here, like you see, this is normal. They're having their hands sticked out, palms facing up. Pronator drift, they would see the inability to keep their palms up. Another thing with EPS or Parkinson's-like symptoms, a shuffling gait, pill rolling motion, like their hands will kind of just do this pill rolling motion after they had a pill in between their fingers. And then dystonia, this is kind of goes similar to the resting tremors. It's just muscle spasms in different parts of their body. A tongue is a common one. Having a spasm in their face is a common one. Usually that's later stages of EPS. So what is the treatment for these EPS-like symptoms? So we can't we can't, counteract the dopamine decrease per se because then we're not really treating their schizophrenia or their schizoaffective properly. Um, but what we can do is treat the acetylcholine part of it. So if you have too much acetylcholine, you can use anticholinergics. So from pharm, when you guys learned like parasympathetic nervous system versus sympathetic nervous system, um, if you guys recall, because I'm sure by now, you guys have gone over that. Your sympathetic nervous system, your fight or flight, is controlled by norepinephrine, while your parasympathetic system, your rest and digest, is controlled by acetylcholine. So, um, something that is an anticholinergic are things that turn off that parasympathetic system, and kind of regulate your acetylcholine. So in this case, anticholinergics make sense for this condition because it's caused by too much acetylcholine. Do you need to know the specifics of the pathway behind that? For this class at least, no. As in for your farm, I'm not really sure how your farm slides are because I don't have access to that class. But when it comes to this class, you will need to know Benadryl and benztropine or cogentin. And if you don't know Benadryl, generic name, it's diphenhydramine. Both of these are anticholinergics, and they're the ones that are most typically used for these tremors caused by psychiatric medications, caused by antipsychotics. So when it comes to um, usually you will see cogentin if it's a routine medication. They'll get like 1 milligram of cogentin alongside their antipsychotics. When it comes to um, some of the emergency injections. So that we talked about booty juice, we talked about the B52. So that would be the combination of Benadryl, combination of Haldol, which is an antipsychotic, and the combination of Ativan. So they get 50 milligrams of Benadryl with 2 milligrams of Ativan and 5 to 10 milligrams of haloperidol in one injection. Um, you have the antipsychotic, you have the benzo to calm them down, you have the Benadryl to counteract some of the shakiness that they could get right away from being directly injected with the Haldol. Plus, Benadryl also has a sedating effect if you've taken Benadryl to fall asleep, makes you fall asleep. So all of that has like a sedating effect, but it's also giving them like a heap of medication for agitation and psychosis. Any questions on EPS? Does it make sense why you take these medications in particular for what's going on here? Yeah. And then kind of going back to the side effects, we talked about it last time. When in doubt, a lot of these medications are anticholinergics for psychiatric patients. So when in doubt, if you're asked about side effects, very likely you're going to have the anticholinergic side effects. So that would be the can't see with dilated pupils, uh, can't see, can't spit, so dry mouth, urinary retention. You'll have urinary and bowel retention, so constipation. So can't see, can't spit, can't piss, can't shit. So all of these go with the anticholinergics. So yeah, when in doubt, you'll probably have one of these. Sometimes a dry mouth can cause a cough, so you can potentially consider that one as something as well. It's because of this dry mouth caused by a lot of these psychiatric medications that it's not uncommon for a lot of psych patients to have hyponatremia because they're drinking so much water and they're diluting their own um, sodium levels from so much water, drinking so much water. Okay. The next one is neuroleptic malignant syndrome, also just known as NMS. This is essentially um, caused by too large of a decrease in your dopamine due to your antipsychotics. So I guess um, let's see, excessive decrease. Yeah, antipsychotics. So if this condition if this is being caused by your antipsychotics, naturally the first thing you're gonna do is stop the medication. We're gonna stop the medication. We're gonna treat the symptoms. Um, Benadryl or anticholinergics are gonna be effective as well for helping with what's going on. Additionally, you can get um, medication that increases your dopamine levels, which would be like similar to the medications that somebody that has Parkinson's would take. But typically, the main things you're doing is treating the symptoms overall, DCing the medication, and then maybe some anticholinergics for the kind of what they're going to be kind of going at. This condition is very similar in terms of side effects as serotonin syndrome. So you're still going to have the hyperthermia. So um, you're still going to have things go up, basically. Increased temperature, increased heart rate, increased blood pressure, increased breathing. You're going to be sweating. The main thing that separates serotonin syndrome from NMS is going to be how rigid and like your reflexes. So someone with serotonin syndrome is going to be have hyperreflexia, meaning they're going to have heightened reflexes. So if you were to do like the hammer test on their knee, they would kick very hard, as opposed to someone with NMS who is actually going to be very rigid and not have any reflexes or very little reflexes. That's going to be the main differentiating factor. But both symptoms they're rare. Um, but if they are occurring, they're treated very similar. Just DC the medication, treat the symptoms. Um, but yeah, so serotonin syndrome, it's why you're not really going to be prescribed two SSRIs at once. NMS, I would probably say is more likely just because it's very common to get multiple antipsychotics at once, depending on how bad their condition is. But usually you'll see EPS, and then depending on how consistent they've been getting everything, it would be you'll see tardive dyskinesia. So the main thing about tardive dyskinesia when it comes to testing is that this is basically like a permanent, kind of like a permanent EPS. Medications will not treat it, and you're not really at this point like it's permanent. You can't really do anything about it. Even if you stop the antipsychotics, it's not gonna change. The very common words that you'll see, like if you get a question like what's going on, you'll see lip smacking is a common one, rolling off the tongue and lip smacking, sucking and smacking movements of the lips, So a lot of like lip and tongue act and like tongue movement, involuntary movement, chewing motions, overall involuntary movements, but drooling can also happen. Overall, it really is just it's focused on a lot of these lips and tongue movements. That's how you can kind of differentiate like the tardive dyskinesia from just like an EPS. Um, so EPS can get better with medications. Tardive dyskinesia is permanent. It's a big differentiating factor, and lip smacking and like tongue movement are going to be some of your um, major side effects or major signs and symptoms there. Okay. And then treatment for schizophrenia, your biggest thing is going to be safety because these people have the highest risk of being dangerous to themselves, being dangerous to other people, or not being able to attend to their basic necessities. And then medication adherence. It's very difficult to have people adhere to these medications, both because because their psychosis is preventing them from being consistent with their medications. Additionally, remembering to even take your medications daily can be difficult. So some people might do better on the long-acting injections. So, uh, like getting monthly shots of antipsychotics, because it's easier to remember the one than to not remember or to remember the one injection versus remembering to take a pill every day. But then, of course, if they were to forget that injection, uh, usually the way they treat it, if like they don't know if they got the injection or not, and there's like they don't have record of it or something, is that they would have to treat it as if they already got the shot because they don't want to double give a shot. So they might be if they don't adhere to it, they might be going longer without medication. So it has its ups and downs. But antipsychotics, they're going to be broken down into your typicals, which very strongly block your dopamine receptors. So because they're very strongly blocking them, these have the highest risk of EPS and NMS, as well as tardive dyskinesia. While your atypicals, and then also it's worth noting that your typicals will primarily treat your positive symptoms, and they're very good at doing that. But they do have that risk of increased risk of EPS and NMS and tardive dyskinesia. But that's how they work. So now going back to your going to your atypicals, these are going to block your dopamine receptors still, but they're also going to help rebalance your serotonin receptors. So if we go back up, the neurotransmitters mainly involved, dopamine and serotonin. And the serotonin part can contribute to mood symptoms. So that's usually that can be thought about like your negative symptoms. So your atypical medications are going to treat both positive and negative symptoms. The trade-off is going to be that they're not as effective at treating the positive symptoms as the typical medications. But if you can get away with the sorry, with the atypical medications, you would rather have that because they're not gonna have as much side effects. They're not gonna have um all the risks that kind of come along with it. So the risk of tardive dyskinesia can be very scary. But then also it would also treat their negative symptoms, their um asocial, lack of energy kind of symptoms. And then here I have listed some examples of typicals. So typicals, they will end in zine. So Z-I-N-E, they will have that ending. So examples are chlorpromazine, thorazine. This is considered the first antipsychotic. Flufenazine, so enzenzine. And I put down their brand names as well, just in case. And then the one that's atypical and sorry, let me not use that phrase. The one that's does not follow this ending, but is still a typical medication is haloperidol, Haldol. So just remember if you can remember the booty juice has Haldol in it, you know that that's like an emergency one, so you're going to want to use the really strong stuff. So that's why haloperidol is a typical because it's stronger. It affects the positive symptoms better. And then some side effects, anticholinergic side effects. Um, you're gonna have sedation, sexual dysfunction, and this right here, hyperprolactinemia, means you're gonna have an increased release of prolactin in your body. So if you guys remember from L&D, prolactin is one of the female hormones. Well, guys have it too, but a hormone that helps to promote the growing of breast tissue and also lactation. So in even male patients that are taking antipsychotics, they can develop gynecomastia, meaning that they develop breast tissue. Um, and then they can also start having production of milk because their body's releasing too much prolactin. And the relationship there is essentially that your dopamine also helps to regulate your prolactin levels. So if you're decreasing your dopamine, you're also decreasing the regulation of prolactin, which is why it builds up too much in the body, which is where then you get lactation, um, gynecomastia, which is I can take a picture. Gynecomastia, basically what they call man boobs, but not due to weight per se, just due to hormones. So very triangular, and part of that is due to you do create breast tissue. You have breast tissue underneath. So even if you were to lose weight or whatever, you would still have this there because your body has developed breast tissue. Looking at a different picture here. Okay, any questions on the typical antipsychotics? So more effective, but more side effects. Only treat positive symptoms. And then your atypicals, these are going to end in peen or pine. Oh, I guess peen because all the other ones are pronounced peen. Uh, Done and piprazole, technically it's edone. So examples here, aripiprazole, Abilify, olanzapine, Zyprexa, risperidone, Risperdal, paliperidone, Invega, and then the ones that don't fit this mold, quetiapine or Seroquel, and then clozapine. You're gonna want to know clozapine. Well, I guess clozapine does fit this one, but it's just very important, so I kind of separated it out. This is the one they're gonna be really focused on is the clozapine. The brand name is Clozaril. So, Clozaril. So again, they treat positive and negative symptoms. They're not as effective for treating positive as the typicals, but they're still effective. And then the side effects, um, the main thing with the negative ones, the atypicals, is that they have metabolic side effects. So increase weight gain, increase blood sugars, increase risk of obesity, higher blood pressure, and high cholesterol. So metabolic side effects. And some of these medications can also, again, they have a higher risk of weight gain. So for example, olanzapine has a much higher risk of weight gain and a risk of becoming obese and having all these issues, metabolic issues, diabetes. Uh, while some, like I believe Abilify, um, is not as bad for weight gain and all that stuff. So it depends on the medication, depends on um, kind of what's going on. Another med that I just remembered, lorazepam. This one's also this one's also weight neutral. It's not going to make you gain weight. Okay. But yeah, so that's the main difference. Atypicals are going to have metabolic side effects, and they're still going to have EPS, just less, and they're still going to have high release of prolactin, just less. So then with clozapine, the thing you need to remember is that it has a risk of agranulocytosis, which is going to be issues with like inability to or lacking in some of your immunity cells. And this is a very serious side effect because it can very highly increase your risk for infection and inability to fight off infection. So somebody that is on clozapine needs to have their ANC, their absolute neutrophil count, done weekly for the first 6 weeks, and then it kind of maybe like once a month once they see that it's stable. But this medication requires blood draws. It's a very strong medication. So some side effects that are additional to it would be like drooling, very common to have people drooling, much higher risk for metabolic issues. So it's a very strong medication. It's very effective, but it poses the most risk of both this condition and then also of EPS and tardive dyskinesia. So it's still atypical because it treats positive and negative symptoms. But it's not a first line medication because of how high risk it is. It's basically like a last resort medication. And then here's just a kind of um, summarizing all the side effects that you can have. You can also have orthostatic hypotension as something that happens. And again, when in doubt, anticholinergic side effects. And then here's some considerations. So, um, severe positive symptoms, typical or atypical can work, but if it's severe, they might require a typical or clozapine. If they have a lot of negative or cognitive symptoms, then you're going to want to go with the atypicals because that's actually going to treat it. Patients that have a lot of metabolic issues, like they already have diabetes, heart disease, kidney impairment, liver impairment, or they're at a high risk, you might want to avoid some of the higher metabolic risk medications like olanzapine, risperidone, and clozapine. And then always there's going to be consideration for those tremors, the EPS and prolactinemia. And then, of course, adherence is going to be massive because people are very non-adherent on these medications, both because their symptoms prevent them from remembering to take them. They, for some reason, just don't want to take them. They don't trust it. Or even the side effects. So some people might be like, I don't want to gain weight. I don't want to take this med. I don't want to gain weight. Okay. Any questions on schizophrenia? ADHD should be a lot faster. Okay. So ADHD, a lot of us probably have it, but it's going to be characterized by poor attention span, difficulty controlling behaviors, and hyperactivity. As for the super deep patho, you don't need to know the super deep patho, but it's caused by um, having a very disorganized and very erratic dopamine and norepinephrine signaling. So the way that kind of works is you have like you can imagine you have neuron one and then you have neuron two, and in between there you have a release of your neurotransmitters from one way to the other. You can imagine that somebody that does not have ADHD kind of gets those signals sent out at a more steady kind of pace towards the other neuron. Study more direct uh, transmission over to the next neuron, while somebody that has ADHD is having a much more erratic and disorganized. So instead of having that straight to the point signal, steady signal, you'll have maybe like this very disorganized, very erratic kind of signaling here. Maybe you might release too much all at once. Um, just the point is it doesn't properly get to the right, uh, doesn't make that connection properly. That signaling is off. It's disorganized, it's inefficient. So you can see instead of a straight line, you have it's kind of spread out everywhere. It's releasing more than it should, and it's not getting the signal is not really being clear to the other neurons. So that's where you kind of have those conditions. And then it might be signaling at weird times. So you might have the signal, this organized signal might take effect at one point and then erratically take place at another point where on a different person without ADHD, they would have it at a consistent, steady pace. But in terms of like specific stuff, um, in terms to understand the medication, I would say you just need to know that it's inefficient, disorganized, and erratic signaling of norepinephrine and dopamine. So you're going to want to know dopamine and norepinephrine. People with ADHD have a higher risk of the showing depression, bipolar disorders, substance abuse disorders. One of the things that they can have is they can be impulsive. Impulsivity is very common. So impulsivity can present itself as gambling addiction, alcohol addiction, shopping addiction, etc. So some signs and symptoms: difficulty following instructions properly, very easy to distract, difficulty remembering things, misplacing items, being impulsive, having a hard time sleeping, excessive talking, and inability to sit still. So if you guys recall from what I mentioned, your norepinephrine is going to be your main neurotransmitter in this scenario, but your norepinephrine is also controls the sympathetic nervous system, so your fight or flight. So that is kind of why people with ADHD kind of come off as being can be like elevated or yeah, I guess just elevated. They're very hyperactive, they're elevated because it's almost like having like you on caffeine basically, just more elevated due to the increased norepinephrine. Although it is worth noting that very specifically ADHD is due to this signaling happening specifically in the prefrontal cortex, which is the front part of the brain. Um, so it's very specifically that it's not entirely a systemic thing per se. So it's not going to present the same way someone that is taking meth or someone that is on stimulants and or medications that release norepinephrine um, when they don't have ADHD is going to present because this is specifically happening in a specific part of the brain. This is where that signaling is inefficient and disorganized. So for your pharmacology, you have non-stimulants and stimulants. So by definition, non-stimulants are going to be less effective, but they have fewer side effects and they're definitely much less likely to be abused. There's definitely people with ADHD that, could use their Adderall, but they abuse it. They use it like a drug. They take more than they should. They just use they're using it to get high. So more likely to be abused with the stimulants, but non-stimulants less so. So non-stimulants are going to be milder and slower acting, but they're more targeted to that PFC, which is the prefrontal cortex, that part of the brain where I said specifically that is where that disorganization, uh, inefficient and erratic signaling is happening. So the one seems to she wants you to focus on the most is atomoxetine, which is Strattera. So this is an SNRI. Notice the small s, not to be confused with SNRI with a capital S. SNRI with a capital S that we saw last week, that's a serotonin norepinephrine reuptake inhibitor. Strattera is the S is actually stands for selective norepinephrine reuptake inhibitor. So what does that mean? It means that once you send out that norepinephrine signal, this medication will um, This medication will keep it in your system. It will not, once the signaling has been done or start finished going, your body will not take as much of it back. So you'll keep it in your system more. So the idea is that by blocking the reuptake of norepinephrine after it does its thing, you'll have an enhanced signaling because the norepinephrine that is already active in the synapse. So as you're shooting between neurons and neurons, that norepinephrine stays active more, more because you're not taking away as much as you would normally. So your side effects for that include um, a headache, insomnia, so upper abdominal pain, decreased appetite, nausea, dry mouth, which can lead to cough. And a lot of these are, again, similar to what you can imagine with like someone that's having everything go up. So less sleep because they're more anxious, they're more tremory, they're more elevated. Upper abdominal pain because decreased GI motility, so decreased appetite as well because they're more in like a miniature fight or flight mode. Because of the norepinephrine increase stays more in the body, so more of a bit more of a fight or flight mode, which is why also you get more attentive because fight or flight you are with that proper signal. Um, and then the additional norepinephrine in your body, you're more alert because fight or flight is supposed to give you alertness. Okay. Another medication that can be used for ADHD that's not a stimulant is Wellbutrin. So this one's a norepinephrine dopamine reuptake inhibitor. So it keeps more norepinephrine, keeps more dopamine. Again, same idea, enhancing the signal. The one thing that I would say would be the most important thing to remember about Wellbutrin versus Strattera is that Wellbutrin um, will also decrease your seizure threshold, meaning that you will have an increased risk of seizures while you're taking it. And then if you abruptly take it, you're going to have like a rebound effect and you'll definitely have a much higher chance of having a seizure. The next class of meds, she didn't really put any detail on it, but and I also marked it as cyan. So again, the cyan color means it's like extra info. But the medications that are included here are clonidine, which we probably have seen in clinical for blood pressure, specifically the extended release for ADHD, and guanfacine, which is also a blood pressure medication. Um, so typically, when you think about things that are decreasing our blood pressure and maybe our heart rate, we think of it as blocking, like a beta blocker is blocking um, that sympathetic nervous system from working. So the reason I included all this info is in case you were curious, in case you were like, wait, why does the med that increases the norepinephrine help ADHD, but then also the medication that decreases your sympathetic nervous system also help with ADHD. Um, so here I do have that explanation there. The idea of these medications would be that they decrease the overall amount of norepinephrine being sent out, but it's kind of like taking a hose and like you spray a bunch of water, but as you tighten it up, it becomes more pressurized and more accurate. So the idea is that these medications kind of slow down your norepinephrine release and makes it more organized and more steady. So you have a more consistent application of it as opposed to um, just it's still being kind of all at once. So that is how that is helpful for that. Don't have to know the exact pathway, but if you are interested, I did list it down here. The main thing would be just basically better signaling, more organized signaling. This one's a enhanced signal. So once you are make the signal, it's a longer lasting, better signal. This one is just a more efficient signal, more organized signal. Okay. And again, because these are also used for blood pressure, you're gonna want to watch out for changes in their blood pressure, changes, orthostatic hypotension, etc. Okay. And then lastly, the other medications that uh, we know about for ADHD are stimulants. So what makes something a stimulant? Even though these medications are stimulating, they're not considered stimulants because by definition, a stimulant is something that increases the release of norepinephrine and dopamine and also inhibits the reuptake. So these are just inhibiting the reuptake. These also, stimulants also cause you to release more. So they have a much stronger and more systemic effect on the body. So you're going to have more side effects as well because of that. And you have a much higher risk of being abused, being having the of the meds being abused. And then again, if you want to think of it like the signal, it's going to be amplifying the signal as opposed to just enhancing it. It's going to be very much amplifying the signal. So now instead of having a signal that sticks longer, having a more organized signal, you're just spraying so much that it ends up like it's going to hit where it needs to hit because you're spraying so much because you got so much going on. You have so much more norepinephrine that it's going to um, it's almost like you're going to have a more steady and more long-lasting signal because you have so much extra going on through the increased release of these neurotransmitters. So the medication she wants you to focus on is methylphenidate. So we're not even talking about Adderall. We're talking about Concerta or Ritalin. This is, I believe, the first ADHD medication. So main things to know, some side effects because it's a stimulant. And again, we are increasing norepinephrine release directly. You're going to have elevated blood pressure and heart rate. It's going to basically put you in a more fight or flight kind of um, kind of state. So, when we're fight or flight, we're not going to be eating. We're not focused on eating. So, very common that it suppresses your appetite and makes you not want to eat. Can make you very nauseous because again, everything's elevated. So GI motility is going to be down. So nausea, maybe all that stuff's going on. Can make your heart rate become irregular because norepinephrine, again, is having an effect on the heart. So some people just might not be candidates for stimulants for ADHD because of pre-existing conditions or because they already have a history of substance abuse. So right, yeah, like right here, contraindications, history of substance abuse, history of high anxiety, agitation, psychosis, and I would say probably risk of heart condition. Mhm. And then also definitely if you are someone that has bipolar and ADHD at the same time, you don't really want to be taking stimulants either because that can make you more likely to become manic, can trigger your manic episodes. So similar reason for why someone with bipolar depression does not want to be placed on an SSRI without also being put on a mood stabilizer because the SSRI is going to elevate them, sure, but then it can also increase them becoming hypomanic or just manic in general. And then some drug interactions. The methylphenidate can decrease the effectiveness of your anticonvulsants and anticoagulants, so increase clotting when you're taking this, um, increased risk of seizures despite having these medications because it's going to decrease that effectiveness. And then some non-pharmacological therapy for ADHD. It includes these such as the following: reducing stimulation. People get very overstimulated. Noises can really upset them or trigger them. Loud noises, people chewing, just too much going on at once. Maybe the TV is playing while this is happening and people are talking, make them overstimulated. Promoting self-esteem is important, and positive reinforcement can be important as well. But and it is possible to kind of be able to cope with your own ADHD as you kind of move on and maybe need to rely less on medication. Um, but it's still it can be like a struggle before you kind of develop those coping skills. So you might have to develop your own little systems. Like I have a designated designated spots for important items. So like I have a spot for my keys, I have a spot for my wallet, I have a spot for my badge. That because it's dedicated, I know where it's supposed to be. I'm not going to misplace it. Do I still misplace things? Yes. I started incorporating a system where like before I leave the room or something, I check that I have all my stuff. Like I came in with my pen and my paper. Do I still have my pen on my paper on me? Cool. Then I can exit the room instead of just kind of exiting the room and then I leave my paper and then I'm looking for it everywhere. And does it still happen? Yes, but it's still an improvement. Um, is there any questions on ADHD? Any lingering questions on schizophrenia or schizoaffective? Kaylin says if you have questions on ADHD, you can ask her because she has it. Okay, no questions. I'll just give you guys the file. Again, the yellow is important. The cyan looking color is like extra info. So I hope that was helpful. I'm gonna post this in the chat. End the recording.